Patent ductus arteriosus. It results when the fetal ductus arteriosus fails to close after the birth. The ductus arteriosus is a connection between the proximal descending aorta and the proximal left pulmonary artery. It allows blood to shunt right to left into utero and effectively bypass the unexpanded fetal lungs, which have inherent high vascular resistance. After the birth, the ductus typically closes within the hours as the pulmonary vascular resistance drops and the blood oxygen tension rises and the maternal prostaglandin dissipates following disconnection of the infant from the placenta. PDA represents 5 to 10% of the congenital cardiac defects with the female predominance of 2:1. At the several days of the age, the prevalence of the PDA is 20 to 80% depending on the age of and birth weight. The incidence of the PDA in full-term birth is roughly 1% at 1 month, but the incidence drops to 0.5% at 2 months. The majority of the infants with PDA at 2 months of the age will not experience the spontaneous closure. The incidence is much higher in preterm, extremely low weight infants approaching up to 50%. The PDAs are often associated with many other congenital cardiac defects, with some regions being ductal dependent and thus necessary for neonatal survival, including the interrupted hypoplastic aortic arch and hypoplastic left heart syndrome. By approximately 21st day of intrauterine life, the bilateral paired dorsal aortas are present. Subsequently, the pharyngeal arches 1 to 6 form bilaterally to connect the aortic sac irrespective of the dorsal aorta. The final arch and the ductal anatomy as well as the sidedness is dictated by the combination of resorption and persistence of these pharyngeal arches. The ductus arteriosus is normal left-sided arch anatomy, arises from the persistent left 6 pharyngeal arch. As a result, the ductus has an aortic end distal to the left subclavian artery and the pulmonary end at the junction of the main and left pulmonary arteries. Interestingly, the recurrent laryngeal nerves are pulled into the chest by the lowest persistent pharyngeal arch during the process, due to the fact that the left 6th aortic arch persists as the ductus in the normal anatomy, and the recurrent laryngeal nerve loops around this structure at the time of the final development. In turn, the right 6th aortic arch disappears during the normal development. The recurrent laryngeal nerve on that side is associated with derivatives of the lowest persistent right arch, and this is the right 4th arch, the subclavian artery. Due to the absence of the 5th aortic arch, the location of the recurrent laryngeal nerve becomes particularly significant in surgical repair in order to avoid the injury to recurrent laryngeal nerves. So the defects of the truncal septations are persistent truncus arteriosus, transposition of the great arteries, and tetralogy of Ferro. During the fetal development, the blood is shunted away from the lungs into the aorta via the ductus arteriosus due to the high pulmonary vascular resistance and unexpanded lungs. The ductal patency is maintained by low arterial oxygen saturation in the fetal circulation, and the prostaglandins, mainly PGE2 produced by the placenta after the birth, expansion of the lungs decreases the pulmonary vascular resistance, and the placental removal causes the increase in systemic resistance. The shunt at the level of the ductus usually reverses to become the left to right shunt, thereby increasing the pulmonary blood flow. In normal circumstances, the ductus closes with hours after birth due to the ductal smooth muscle contraction. The drive behind the contraction has been linked to several factors that include the increased arterial oxygen content as well as decrease in the circulating prostaglandins from placental loss and increased degeneration of the lungs. Preterm infants also tend to have pulmonary compromise from underdeveloped lungs, which decreases the arterial oxygen content and may promote the prostaglandin synthesis, thus contributing to a ductal persistence after birth. The preterm infants are more responsive to prostaglandins than term infants due to the differences of the cyclooxygenase enzyme during development. In the premature infants, the PDA increases the risk of the prolonged ventilation, pulmonary hemorrhage, and bronchopulmonary dysplasia. The diastolic steal through the PDA can cause the renal hypoperfusion, interstitial ischemia, necrotizing enterocolitis, and reduced cerebral perfusion, and increase interventricular hemorrhage, and mortality without the intervention is hemodynamically significant. PDA is about 30% in the first year of life. In less than hemodynamic significant ones, the mortality estimates at about 60% at 60 years of age if left untreated. Long-term persistence of PDA can increase the risk of endocarditis, heart failure, obstructive pulmonary vascular disease. The prenatal use of ACE inhibitors is associated with PDA through an unknown mechanism. Both congenital rubella and neonatal sepsis in premature infants are also associations. The factors restricting the ductal closures include the decreased intrinsic smooth muscle tone, higher circulating prostaglandins, and increased sensitivity to vasodilatory effect of PGE1. So PDA leads to left to right shunt, increasing the pulmonary venous pressure, increase in the pulmonary edema, decreased blood flow to the skin, bone, muscle, GI tract, and rapid increase in the pulmonary blood flow, increasing the pulmonary hemorrhage. Shunting through the PDA occurs through both systole and diastole with significant increase in the pulmonary blood flow to a greater degree with intracardiac shunting, and this leads to the early heart failure symptoms and accelerated development of the pulmonary hypertension. In neonates, the heart failure can present as a poor feeding, lethargy, respiratory distress, tachycardia, diaphoresis, hepatomegaly. Pulmonary overcirculation with decreased systemic circulation can cause hypotension, pulmonary edema, and failure to thrive in infants and young children. Neonates, especially the preterm, are at the higher risk of intestinal ischemia and renal failure. A continuous machinery-like murmur is generally present at the left upper sternal border. White pulse pressure and hyperactive precordium can be present. The late presentation in smaller, less significant PDAs can include shortness of breath, frequent upper respiratory tract infection, and slow growth, fatigue, and decreased appetite. The late presentation in the large previously untreated PDA can include pulmonary hypertension and eventually Eisenmenger's syndrome. Cyanosis is generally presenting sign in older patients with a PDA who have reversal of flow with right to left shunting due to systemic levels of pulmonary hypertension. Chest X-ray can demonstrate cardiomegaly, pulmonary edema, and increased pulmonary vascular markings. Adults can have calcifications of ductus seen on the chest X-ray. Electrocardiography can demonstrate the right, left, or biventricular hypertrophy. The transthoracic echocardiography is the standard for diagnosis, and echo will likely demonstrate the flow reversal with retrograde flow on the descending aorta, indicating left to right shunting. The constant left to right shunting through the PDA concerning for the pulmonary hypertension. Adults may need cardiac catheterization to delineate pulmonary pressures. If surgery is planned, both arch anatomy must be delineated as determines the surgical approach. In addition, the evaluation is associated with the cardiac defects should be performed, and left ventricular function is important to assess at that time. The shunt fraction can be calculated for PDAs based on the QP and QS, pulmonary to systemic flow, with a small ratio being QP to QS 1.5 to 1, moderate 1.5 to 2, 2.2 is to 1, and large 2.2 is to 1. Complications of PDA are BPD, NEC, and feeding intolerance. NEC is necrotizing enterocolitis. Risk of indomethacin use: decreased mesenteric renal and cerebral blood flow, oliguria, and dilutional hyponatremia, isolated intestinal perforation, and necrotizing enterocolitis. Contraindications is obviously necrotizing enterocolitis, renal failure, bleeding, and hemodynamically insignificant PDA. The indomethacin prophylaxis decreases the symptomatic PDA and the need for surgical ligation, decrease the grade 3 and 4 of IVH, no change in the short-term mortality, no difference in the rate of NEC, and long-term neurodevelopment outcome is not adversely affected. And diagnosed by systolic murmur, which may not be significant, hyperdynamic precordium, bounding peripheral pulses, wide pulse pressure, and worsening respiratory status. Medical treatment focuses on the heart failure management and the pharmacological closure of the PD and the premature neonates. The heart failure management includes the diuretics, inotropes, and afterload reduction. In addition, the limiting decrease of the PVR, helpful to limit the left to right shunting. Methods to achieve include maintaining the spontaneous ventilation, avoiding supplemental oxygen, increase PEEP in the ventilated patient, and allowing for the permissive hypercapnia. Spontaneous duct closure in the preterm infant is rare. Pharmacologic PDA closures using the COX inhibitors to prevent the prostaglandin synthesis can be helpful, but it is often ineffective in terms of the infant due to the lack of the prostaglandin responsive contractile smooth muscles and their ducts. The indomethacin and ibuprofen are equally as effective, notably the side effects of the renal damage, intestinal nephritis, and neck. Intravenous Tanolol for a full 7-day course has been used for PDA closure, as well as within the few doses of indomethacin, the duct closes in 60 to 80% of the patient. In the initial attempts are unsuccessful, 40% chances remains that the subsequent courses will be effective. Dosing the indomethacin 0.1 to 0.2 mg per kg, 12 hourly, up to 3 doses. The indomethacin and ibuprofen are contraindicated in neonates with renal impairment and intracranial hemorrhages. The PDA ligation or closure can be accompanied surgically or thoracotomy and sternotomy or by the VATS. The endovascular approaches using the transcatheter closure devices and coil are also an option, and the surgical closure involves the simple clipping, ligation, double ligation, and division of the PDA. Distinguishing among the pulmonary arteries, the left subclavian artery and the distal aortic arch, descending aorta, and ductus arteriosus can be difficult. Care must be also taken to identify and avoid the phrenic and left recurrent laryngeal nerves. Endovascular closure is accompanied either by the coil occlusion and the laryngeal nerves coiling occlusion in the PDA less than 3 millimeters, or by device ductal occlusion system for the PDA larger than 3 millimeters. These devices are approved for the use in the infants older than 6 months and larger than 6 kg and have a closure rate of 85 to 95% of 1 year. And when used in this population, the newer devices are currently in use for trial basis for smaller newborn. The surgical PDA closure is performed on the premature infants who fail to have contraindications to pharmacological closure. The surgical closure can be performed with the bedsides and the neonatal intensive care unit. The approach in the preterm infant is generally via thoracotomy and with the patient in the left lateral decubitus position, and the PDA is occluded by placing the external clip across the PDA. In the term infant or older patient, the pharmacological closure is not an opinion. The surgical or transcatheter closure remains the only option, and the symptomatic infants should undergo prompt PDA closure. In symptomatic infants, the elective closure can be done between 1 to 2 years of age, VATS or transcatheter approach. Closure is indicated in moderate and large PDAs with symptoms of the left to right shunting, left to right volume overload, or reversible pulmonary hypertension. The closure is also indicated to reduce the risk of endocarditis and pulmonary hypertension in future. The preoperative cardiac catheterization with pulmonary vascular resistance measurement should be performed in any patient with cyanosis or bidirectional shunting through the PDA. Closure is contraindicated in patients with elevated PVR that fails to appropriately drop and expose to oxygen and nitric oxide. Transcatheter closure is limited by short length and the large diameter of the PDAs, as each of these features increases the risk of transcatheter device embolization, among other complications. The adult patients can have extensive ductal calcification, increased bleeding risk during the surgical PDA ligation. Sternotomy may be required in adult due to possible need for deep hypothermic circulatory arrest to safely dissect and close the calcified ductus. Complications after the surgical PDA ligation include the left recurrent laryngeal nerve injury, bleeding, postoperative chylothorax, and coarctation development. Antibiotic prophylaxis is generally indicated after the transcatheter PDA closure, but not after the surgical ligation. The operative mortality is rare except in high risk and low birth weight with a very preterm infants in whom the hospital mortality should be about 20%. The long-term survival after the PDA ligation is high and reintervention is rare after the early surgical ligation. These are the steps of the PDA ligation. Thank you. Hope you have enjoyed this lecture. If there's any feedback, then please let me know. Thank you.